So we also know from the data that provision of decision support, this is the data from Kawamoto published in the BMJ in 2005. We know that if you put decision support on people's desktops, on their mobile phones and so on, then actually you get a 15-fold increased uptake of that information to close that gap. But here's the interesting one. If you automatically put it inside electronic medical record systems and appropriately alert and prompt people, then of course you do much better. And that's why we're working very hard with EMIS and TPP and the electronic medical record suppliers, the progressive ones who've got modern systems that can take what's called web services and knowledge feeds to get to that. And that's coming next year. So the third challenge, specialty silos. I think everyone's aware of this, and locum staff and junior doc rotations. I think we'll talk about it a little bit later. But we all recognize the silos of care. We all have our own specialty, whether we're nurses or doctors. We work on different types of wards with gastroenterology, cardiology, primary care, mental health, and so on. And we're all using different reference sources. So the map really is trying to address this issue where the patient's at the center of care, and we're giving the GPS for healthcare for the patient across all the silos of care so that everyone, including the patient, is on the same page. So primary care, secondary care, tertiary care, with mental health and social care running as verticals, but without a common framework of knowledge, without a map, it's very hard to actually guide people safely and appropriately through our care systems. So finally, financial sustainability. Does this cost more? And this is pertinent, of course, to today, the economic environment. And a number of case studies that we've been doing that show very clearly, and I won't go into detail on these, but that if you actually use the map as the design tool and then a mechanism to disseminate that information locally across your organization, both the acute hospital trust, the primary care trust, mental health, and so on, then you actually deliver better quality care at lower cost, as it turns out, because it stands to reason. If you're doing the right things, if you're actually more efficient, then it's typically going to cost less. And the most expensive thing in the healthcare system is when you do the wrong thing and the patient suffers harm. And that brings us back to the final reminder about those four challenges and how we address them with the map. Less is more, visual interface, everyone on the same page, clear differentiation between the different care settings, and fundamentally important, localizable. And with that, I'll hand you over to Dr. Amir Hanan to show you the map in action, so to speak. Thanks very much.
Can I make a couple of comments about that, actually?
Yeah, sure.
Because it's more about physical as opposed to practice.
Yeah.
I think, first of all, I would agree getting sort of self-evidence in practice has been a challenge to health services for a very long time. And you mentioned the new anticoagulant. Also, how quickly do things get into the map? I mean, does the map, the DDT pathway, include the new anticoagulant?
It won't, because the map at a national level follows the national guidance, NICE, SIGN, but it doesn't stop a local organization. This is an important point. If there's a local hematologist who says, look, this is a game changer, and I'm not waiting 2 years for NICE. I'm not going to wait 2 years for NICE to update this. We actually want to do something innovative. It allows you on your local version to put that in safely under a proper governance structure.
So there's going to be delay getting the map, because then if you've got clear
at the national level, but not, yeah.
That makes it very difficult for local innovation. I would disagree with you. I would think it would cycle it. I think it's very difficult in the current climate where it's more about compliance perhaps rather than innovation to actually go against that. And if someone turns, like our commissioners around, turn around and say, well, actually, why are you doing that? That's not in that. And we say, well, if you've not read this article in the Journal of Medicine, this clearly is better and cheaper. I don't think they're going to be convinced.
Well, I'll give you...
Say, well, I'm sorry, we're commissioning service-based on NICE guidelines.
But this is why, first of all, I can say to you for sure that it doesn't, because we know in the world already, Kathy Gertzner, the Director of Commissioning, has used it to shift care and do innovative things already that are not in NICE. So it's up to the local clinical community. This is the important thing about the map. I probably didn't say it strongly enough at the beginning. It's got to be clinically led, locally clinically led, under appropriate governance structures. It mediates a discussion and an argument. The map is not NICE. That's the beauty of it. NICE, yes, absolutely. We rely on NICE. 80 of the 300 pathways in the map follow NICE, the national ones. But of those, for example, hepatitis C, the world's done some interesting stuff where they've shifted care, and a lot of the viral load testing is actually going to be done in primary care. So I would say the evidence shows that no, if the local community owns the map and uses it as its tool to have that dialogue between the different care settings, you do actually promote innovation.
No, certainly other areas are not as lucky to have us enforce sort of forward-looking commissions.
Yeah, yeah.
And I suppose the final thing is practicality. My impression about the use of map is it's fine for areas I don't know what about. So DVTs, well, I see a few cases of them and I don't deal with it regularly. I think it's very useful. However, an area that touches substantive issues which I do work in, it's too brief, too simplistic.
Yes.
It's not particularly helpful. In fact, in some ways it's hindering their commissions to expect them to follow that. They're just not the detail. That would be my observation.
Right, because again, the map is not designed for the specialists in their specialty area. We would expect and hope the specialists would know more, absolutely. But the problem is you as the specialist need to then communicate that out, use the map as a tool to embed your knowledge where appropriate to the commissioning process. So it's not a thou shalt. It must never be a thou shalt. That would kill healthcare overall. So it's up to local people, local leaders and so on, to actually drive that message home. Pleasure.